Hi there. This is Christiana Camp, and I will be presenting my nursing impact project for my capstone, which has been at Strong Hospital on the unit WCC5, which is a surgical oncology floor. So when I started to break down what my PICO question would be, I obviously decided to pick for my population surgical oncology patients. But as I've spent time on the unit, I've also noticed that there is a significant amount of colorectal patients on the unit, which was just a result of the changes that COVID brought. So this PICO question can actually be applied to a lot of these patients, the colorectal patients as well, because they undergo a lot of surgical procedures that may result in different types of surgical sites and wounds. So I thought that was interesting that it can be more broadly applied. But for this specific project, I focused in on oncology patients who are undergoing surgery. For the intervention that I chose a strict blood glucose monitoring system for all diabetic patients and non-diabetic patients, and I will be comparing that to the current standard of care as far as BG control goes on the WCC5 unit, and I'll get more into the specifics of that in just a minute. And then the hopeful outcome is that this stricter blood glucose control will result in a reduction in surgical site infections in these patients. So putting it all together, my PICO question is, in patients undergoing oncological surgeries, does enhanced glucose control versus standard glucose control reduce the risk of surgical site infections? So when I was evaluating the current blood glucose monitoring protocol on this floor, I found out that blood glucose levels are taken for every patient when they take their basic metabolic panel, and that's a blood draw they do at midnight every evening on the shift. But those patients are much less monitored less closely, and it's just a one-day blood draw, and it's generally not something that's intervened on unless it was like a pretty high BG that was like very concerning. Patients that are NPO for extended periods of time or that are receiving TPN therapy are going to get those point of care glucose draws, which is going to be before meals and in the evening time, and they're treated with a prescribed insulin regimen. And then also diabetes patients are going to... Okay. I apologize for the brief technical difficulties, but I'll just pick up where I was. I was saying that diabetes patients also get point of care glucose draws and also receive insulin therapy. So the overarching theme that kind of I noticed on this unit is that although glucose levels are monitored with every single patient on the unit, unless they're NPO, on TPN, or already diagnosed with diabetes, it's not a very strict protocol. And I also thought it was interesting that some of these patients come in like for scheduled surgeries, but others go in for emergent surgeries. And I think it would be very valuable, just as a side note, trying to do more screening for undiagnosed or uncontrolled diabetes prior to surgery. Obviously, that would be more difficult if it was an emergent surgery, but if it was a planned surgery, I think that would be really valuable because, as we'll see in the research, really high blood glucose levels are going to significantly increase the risks of surgical site infections. So moving on to the research, I found quite a few peer-reviewed studies that did a really good job of analyzing the effects of uncontrolled glucose versus a stricter glucose regimen and how they affect these surgical patients. So the first thing I wanted to address, which I thought was really interesting, was just that the Joint Commission released their 2021 patient health safety goals this year, and number 7 for hospital-based goals was reduction of infection. They harped more on hand washing in regards to this, but I think this regimen can also help reach that national goal for our hospitals. So the studies found that uncontrolled glucose levels are positively and strongly correlated with, uncontrolled or high glucose levels have a strong positive correlation to surgical site infections. So if you see the graph in the top left, that shows what one of the studies found in terms of different ranges for glucose levels and how the percentage of surgical site infections that were seen in these patients. And it's a very obvious trend. And throughout my studies, there were some studies that did this on diabetic patients who are obviously at higher risk for having uncontrolled glucose levels. But then there was a few studies I found that did this on the general patient population, those who don't have diabetes. And across the studies, I found that the total range that they were aiming for, some regimens were more strict than others, but generally they were looking for a target BG to be maintained between 110 and 180. And they found in one of the studies a 30% reduction in surgical site infection rates when they maintained a monitoring system that kept the blood glucose below 200, and they did this through an insulin infusion therapy immediately post-op. So that would be like in the PACU into like the surgical unit on the hospital where they recover. And then another study found that post-op glucose levels were the only significant predictor of surgical site infections after a multivariate analysis. So they analyzed multiple risk factors in terms of surgical site infections and what would predispose people the most to a surgical site infection, and blood glucose had the strongest correlation out of age, gender, and other comorbidities that they analyzed, which was really interesting. So some of the gaps in research that I saw were just the lack of repeating these studies. So I was able to find some studies on uncontrolled diabetes patients, diabetics, and then also for non-diabetic patients, but they were kind of few and far between. And I think if there were more studies done, we could strengthen this correlation that we continue to see between blood glucose levels and surgical site infection rates. Another gap in research was that with these really strict protocols, specifically the glucose levels of maintaining around 110, there is a risk for hypoglycemia, and which can obviously be life-threatening. And the unit actually did recently have an issue with one of the patients on the unit that was, I believe there was a miscommunication and handoff, and a patient received their insulin therapy and there was not a meal available and their glucose became very low. So we know that's a risk when we do tighter glucose control, and there is that risk of hypoglycemia, but and some of the studies addressed that risk, but they didn't really offer any solutions in order to kind of reduce the risk of having hypoglycemia in these patients. So I think that would have been valuable in terms of trying to implement this type of intervention in this population. So yes, just in general, we could use more studies and standardized interventions, and strict measurement would be helpful for further establishing these relationships between factors like your HbA1c and your perioperative blood glucose and how those correlate with those surgical site infections. And then in terms of trying to implement this on the floor, I have a couple recommendations. My first would be to have point of care glucose levels drawn for every patient, whether they are diabetic or not, and to have those drawn obviously before meals and at nighttime. And then those patients will be treated with an insulin therapy in order to keep these patients' glucose levels in a lower range than maybe we do right now. So my recommendation would be to have a cohesive goal on the unit to keep all the patients' BGs under 180 at all times. And then those that go higher than 180 should be reported to a provider. And I also think it would be beneficial, based on one of the studies that I saw, that if we were to use insulin infusion therapy more frequently on the unit, because that has been found to reduce surgical site infections. So that would be my recommendations for having a better monitoring system on this unit, and hopefully reducing glucose levels in and result in less surgical site infections, which we know is one of the main reasons patients are readmitted, and that would be really valuable for the hospital as well, as to reduce readmissions. And then finally, some of the barriers that I could see us facing on the unit with these types of interventions is, I'll bring it back to the higher risk for hypoglycemia in these patients, and that would require pretty diligent monitoring to avoid any patient safety risks like the one I had mentioned earlier. So currently on the unit, they have about a 4 to 5 nurse, every nurse gets about 4 to 5 patients during a shift, and usually at overnights and such, that'll turn into maybe like a 6 patient load. So point of care glucose for all these patients may increase the nurse's task load on the unit, which can be a bit stressful. And also the insulin therapy that they would be providing would also increase the workload of the nurse. So it might be valuable to adjust those patient ratios so that it might be a 3 to 1 or a 4 to 1 and not surpass 5 or 6 patients, because again, we want to reduce that risk of hypoglycemia and also be able to maintain this more rigorous protocol that I'm recommending. And then my final barrier that I think would be we'd be able to overcome is just promoting blood glucose control upon discharge, which I know they already do for patients who have uncontrolled diabetes, but really having a nice regimented system in order to make sure these patients have the tools they need to monitor their blood glucose, and just a really diligent education to make sure that they are also not at risk for hyper or hypoglycemia, because we know that surgical site infections are any infection at a surgical site 30 days post-op, and these patients are discharged oftentimes long before that 30-day mark. So we want to make sure that their blood glucose stays in control throughout that, ideally throughout their life, but this more stricter regimen is upheld throughout those 30 days so that we can continue to reduce the percentage of surgical site infections in these patients. And my works cited is down in this bottom corner for reference. And that is all I have for you today. If you have any questions, please let me know. Thank you.